Fact or Fiction, our show on the web for all things fertility, where we try and introduce people to all the myths and the facts and the realities so that you can get the best journey for you possible. And I am your host, Dr. Rahi Victory. I am a reproductive endocrinology and infertility specialist, board certified in both Canada and the US for all things related to REI. So we hopefully have a good show for you tonight. It's really interesting because there's data now on what the top performing centers in the US actually all shared in common. So I'm going to review that article with you so that you can see if your center is doing the things that all the top centers are doing or not. So interesting data there. Hopefully everybody is staying warm. If you're out on the East Coast, everyone got blasted by a snowstorm, and apparently it's coming to Windsor tomorrow, day after tomorrow, Wednesday. We're getting a foot on Wednesday and a foot on Thursday, so it's going to be pretty crazy. And so yeah, everybody stay safe and get your shovels or snow blowers out and ready. Yeah, we're going to get started right away. So the article for this week is called Common Practices Among Consistently High-Performing IVF Programs in the United States, 10-year update. So it's done by some relatively well-known people in the infertility world. The main author is Bradley Van Voorhis, and he's quite well known in the infertility circles. And so they basically took data from SART, which is the American data collection system for all things infertility, and they compiled it and looked at some of the top performing programs and then decided to look at what sort of characteristics they had and compared some of the elements to all the rest of the programs that were available. So they ended up with 13 IVF programs that were doing a minimum of 100 cycles per year and having high cumulative singleton birth rates for the last 2 years. And they looked at all the different elements, and I'm going to go through those with you. So the first thing that they looked at, and I'll pull up table 1 for you here, is the clinical outcomes of IVF in these high-performing clinics in 2016 and 2017. So you can see in the 2016 data that they had a age range of less than 35 and then 35 to 37. So in the high-performing clinics, they're getting a 59% live birth rate, and in the all programs they're only getting 45%. So that's a huge difference. It's a 1/3 sort of increase in the number of pregnancies that they're achieving, because you're going from 45 to almost 60. So it's a huge difference between the all programs and then these top performing programs. When they looked at it in 2017, the difference shrank a little, but the absolute numbers went up a little bit. So 61% in 2017 for the high performers versus 48%. You see a very similar pattern in women that are older, 47% for 35 to 37 and 34% in the all group. And then in the high performing clinics in 2017, 50% in the high performing clinics and 36% in the all other clinics. The percent that had single embryo transfer, which is really important because we really desperately are trying to avoid twins and triplets and so on in our IVF programs, 78% for women less than 35, 71% for those 35 to 37, and then only 56% and 46% when you looked at all programs. So those other programs are actually using more embryos and getting a lower success rate. And that's a really important message to take away, because what it's showing you is that the number of embryos that you transfer does not necessarily automatically translate to success. It's the quality of the program that is as important or more important than the number of embryos, because we get the request to transfer 2 embryos all the time, and we're very gun shy about doing it here because our success rates are so high. And the problem with that is other programs are always using, or not always, but are frequently using 2 embryos. My last embryologist used to like to transfer 3 embryos, but you can really run into high order multiples, and you're not necessarily improving the success rate If you run a tight program and you're getting good results, you're going to get good results. And if you're not running a great program, it doesn't matter how many embryos you put in there, you're still not going to get the kind of robust results you want. When you look at it in 2017, the numbers went up even higher. In the less than 35-year-old age group, you're getting 85% that are doing single embryo transfer versus 68% in all programs, 74% for women that were 35 to 37 versus just 59% in all the other programs. So, all of this data is really critical, important for the stuff that we're doing. When they looked at, the medical practice, one of the things that did turn up to be important was that many of these clinics had a cutoff on the upper age limit of patients that they would allow to try with their own eggs. So the median was 45 years, meaning half of these top 13 were allowing women above 45 and half were below. So the 45 was the median number. The range was anywhere from about 44 to 50 years. 12 clinics had body mass index restrictions on use of their own eggs with a median limit of 40, and we do as well. And only three clinics reported ovarian reserve restrictions. Excuse me. So they said that the FSH cutoff was anywhere from 12 to 25. If your FSH was over 12, they wouldn't do it, or up to 25. So all of these are really important factors to consider. If your clinic has those, they're likely going to perform better. And if they don't have those sorts of restrictions, then obviously they're not going to perform as well because they're taking everybody. Pre-cycle assessments, the majority of clinics, 8 out of the 13, required a uterine cavity assessment within 12 months. So with us, that's our saline infusion sonohistogram. It's probably going to ultimately be our most popular video. It grows by about 1,000 people every couple of days. And so if you want to see what a saline infusion sonohistogram looks like, it's right there on our YouTube channel. You can check it out. So all of these are doing that. None of the clinics perform the mock embryo transfer at the time of egg retrieval or during stimulation. So that's also important, because we don't do a mock transfer because I already know if I'm going to be able to do your embryo transfer or not from your SIS. It's often costly. It requires a lot of injections. It's basically a long waste of time, and it's very frustrating for patients. So not needed in these top tier programs. Supplements for women with diminished ovarian reserve. Most clinics used coenzyme Q10, allowed acupuncture, and discouraged metformin, aspirin, and testosterone, which is interesting because we actually do use aspirin, and we will occasionally use testosterone. They were evenly split on using DHEAS and growth hormone. Some did, some did not. For the average patient with PCOS, most clinics recommended weight loss, allowed metformin and acupuncture, and discouraged using DHEAS, which there is one guy out there who swears that PCOS women should use DHEAS because he believes it's actually deficient in those patients. Coenzyme Q10 and inositol use varied. As you all know, if you're regular watchers of our show, we definitely recommend that for our PCOS patients. For ovarian stimulation, should you use the pill or not? 12 of the 13 clinics use the pill for some IVF starts, but not all. And that's kind of what we're doing now as well. So for older patients or patients with weaker ovaries, we're not using it for them. But for the patients who have stronger ovaries or are younger, we do. All clinics use a combination of FSH and LH, which, as you know, we do as well. So we'll frequently use Gonal-F or Recavel with some Menopur, and that's a great combination. Plus, there's the new Pergoveris drug, which is a combination of FSH and LH from the Serono company. And all these different clinics use these in various dosages. What about progesterone? The majority of clinics, 10 out of the 13, did measure serum progesterone levels during stim. That's only important if you're doing a fresh embryo transfer. It does not have any significance if you're doing frozen. The timing of the measurement of the progesterone varied. About 40% of the clinics tested it on all blood samples, which seems needless. 30% tested it later in stimulation. So They went into the personnel. A lot of these clinics that were top performing had obviously physicians, you have to have those. They had advanced practice providers, which would be like nurse practitioners or physician assistants. We're actually going to have our own nurse Kasha join us hopefully in the near future within the completion of the nurse practitioner program. So we're really excited about that. They had multiple registered nurses, some medical assistants, obviously sonographers, a laboratory director on site. So this is interesting because 2 of the centers did not have an on-site lab director. So that's someone that can go around to different centers. 11 of them did. We obviously have our own lab director here. She's incredible, Dr. Khosravi. So that's really important. They had numerous embryologists, andrologists. They had financial counselors, probably more important in the US than in Canada because it doesn't cost nearly as much here as it does in the US. And then psychological support. And we have a whole network for our psychological support. Only half of the US programs had psychological supports, but we actually have all sorts of it. So we've got an online program called Organic Conceptions. We have our amazing social worker and our psychologist. We have a family physician that often does counseling for us when clients can't afford it on their own. And we also have the ability to use our naturopath, who's also really, really good at reducing stress and providing people with assistance psychologically, emotionally as well. So all of these things, again, really super important to consider. Is your program providing you these things? For the clinics that did fresh embryo transfers, they did advise freezols with a progesterone level of 1.5 to 2 nanograms per deciliter. So if you're looking for whether or not you should freeze and they're measuring your progesterone levels, those are the levels you're looking for. In terms of embryo transfers, the top programs all had single embryo transfers in the first transfer cycle. 3 of the 13 clinics performed only frozen embryo transfers, and 10 performed embryo transfers in the fresh cycle. Again, I find that kind of interesting because we do mostly frozen, but some fresh. For the fresh transfers, there's a split on when they started the progesterone in relationship to the retrieval, with some starting on the evening of the retrieval, which is kind of the most common and probably what you should be doing, and others on the morning or evening after the retrieval. That's probably a bit late. If you're doing a frozen embryo transfer, they had 5 clinics that accepted 6 millimeters as your endometrial thickness, 4 that accepted 7, and 2 that accepted 8. We do aim for 8. And 2 of the clinics actually had no minimum thickness. So again, that's really interesting. These are top performing clinics, but they don't even have a minimum requirement for your endometrium. So this speaks volumes about all of the other pieces that need to go in to your success. It is not just one thing like endometrial thickness or just your progesterone level. It's the holistic approach to this that really matters. And I think that's a big part of why we're so successful as well. All these clinics used intramuscular progesterone. So that's also interesting because we get a lot of people saying, oh, I don't want to use the IM progesterone or PIO as we call it. And it's very clear that the best performing clinics are using this for their transfers. They were anywhere from 120 to 131 hours prior to the transfer. Again, very important because the era people will tell you your window of opportunity is very small. And the reality is that the window of opportunity actually is quite large. As you can see, there's up to an 11-hour difference there. And so the ERA testing, again, is probably useless. 30% or less of the clinics used antibiotics and steroids. We do. Testing for receptivity of the endometrium was either not performed or was rarely performed in 8 out of the 13. So again, these top performing clinics are almost never doing ERA testing. And I think that's really important for everyone to know. And the only time they really did do it, it says, is for recurrent pregnancy loss. The PGTA was quite interesting. So the majority of clinics did offer it to women that were older. And by older, we're talking about over the age of 38. Now, about half of the clinics recommended it for women that were less than 35. two clinics for less than 35, half for 35 to 37, and almost all of them for women that were older. So this is really interesting. And they reported that there was about 0 to 25% PGTA in 3 of them, 26 to 50% in 2 of the clinics, 51 to 75% in 4, and 76 to 90% in 2 clinics. So one clinic almost always used PGTA. Most of them did not consider your ovarian reserve to be particularly important when counseling regarding PGTA. In my opinion, that's a mistake, because we've reviewed data on the show that clearly demonstrates that if your AMH or your ovarian reserve are lower, then your risk of an abnormal embryo is actually higher, so that's important. In terms of laboratory techniques, 4 of the 13 used ICSI for everyone. That would be us as well. 3 reported male factor as the only indication for ICSI. The top 3 other indications were male factor, frozen sperm, or unexplained. When asked about additional tools, none of the labs were using these fancy things like polarized light microscopy or anything like that. And most of them just use standard techniques to choose which sperm, rather than the high magnification or ultra high magnification or the PIXI techniques. They don't show any benefit, and we've reviewed that on previous episodes of Fact or Fiction as well. Assisted hatching, variable between the different programs. Some did, some didn't. So that was really quite interesting as well. All these programs used vitrified embryos at the blastocyst stage. So they're using vitrification for freezing techniques, and they are waiting until they're blastocysts rather than just day 3 or day 4. Most of the labs collapsed the blastocele before vitrification, and all of them said that the shortest recovery time once they thaw is 2 hours, and the longest was only 5 hours. So you don't want to leave the embryo in there for too long. Air quality control was important. That's probably boring for you guys, but there was a lot of that. Most of them used tri-gas, which we use as well. Many of them had different types of incubators. There was no consensus on what type of culture media they're using. This starts to get kind of nitty-gritty lab. And then in terms of performance indicators, for quality assurance, their fertilization rate was the #1 thing. Our fertilization rate is sky high, typically over 90%, 95% in some cases. So I think we're doing quite well there. And most of them looked at the blastocyst or the blastulation rate for another quality indicator. So overall, your program really wants to have an amazing setup in terms of a very holistic approach. You want to have lots of people there to service you. Smaller programs with few people will have a harder time maintaining the same success rates. I'm proud to say VRC now has 34 employees, and we're about to hire 2 more, so we'll be growing rapidly. And so we do have the personnel here. In terms of techniques, progesterone was important. Blastocyst is important. You do have the option of fresh versus frozen. All of these programs are really doing single embryo transfers and still achieving higher success rates than the programs using double embryo transfer. So we do try to avoid that as much as possible. And then, of course, the actual lab techniques, air quality was important in terms of making sure that they got the right kind of filtration of air and the right delivery of gases. We actually have 4 different levels of air filtration. We have centralized air filtration. We have systems built into our ventilation system that kill viruses and bacteria. We have this great big unit that is known to suck in all kinds of bacteria and viruses and kill them through something called a plasma coil. We have it in each of our patient rooms as well. For COVID, we've had 0 patients get ill from here in the clinic. And then we have forced air for positive pressure ventilation, which all of these 13 programs had. And then, of course, we have our laminar flow hoods as well to do all of our technical stuff underneath the hood. So all of these things are really important. There are some common features that make a program better than some of the other programs out there. And it's substantial. You're looking at about a 30% increase in success which is kind of what we see here. So if you're trying to decide if your program is the right one, these are some of the markers to look at. This study is available on fertility and sterility as part of the current journal, and you can pick it up there and take a look. So I hope you enjoyed that and learned something from that. If you have questions about your center or you want to know about our center, don't hesitate to reach out. You can find us online, and it's just info@drvictory.com if you want to set up a time to visit with us. Otherwise, definitely check out our YouTube channel and our Instagram. Make sure you follow and like, and if you have comments, we're always open to your comments, to send us your comments so we can check those out. And with that, we will take your questions.
What is the success rate of the IUI?
Well, IUI success rates vary depending on your diagnosis and depending on whether you're using pills or shots. So if you're using IUI with, for example, just PCOS and you're young and you're healthy, you can get a 15% chance. If you're using it with injectables, it can go as high as 20, 25, in some studies as high as 30%, although that's rare. If there's severe male factor and you're trying IUI, your success rate can be as low as 1%. So the diagnosis is really critical. We need to know what the quality of the eggs are, what the quality of the sperm is, and then based on that, we can determine what your chances are going to be. Age plays a huge role. As I mentioned, your diagnosis plays a huge role. The quality of the sperm plays a huge role. So there's no single number. It can be anywhere from 1% to a maximum of about 25, 30% using very healthy people with good quality sperm and injectables. So hopefully that gives you some kind of range to work with when you're thinking of that.
How many and what size follicles are ideal for IUI?
This absolutely does not taste like mango juice. Tarek and I had dinner and we bought mango juice that has no relationship whatsoever to mangoes. The size of the follicle, the optimal follicle size was determined in a relatively recent study to be between 19 to 21 millimeters. That was about 6 to 8 months ago, I think. And so we target that range unless we're getting too many follicles. And then, of course, we have to back it up a little bit. But we aim in general to trigger when you're around 17, 18, 19, 20, 21. You don't want to pass that because they're post-mature. You don't want it too early because then you'll get some immature eggs.
Are any laxatives safe during pregnancy?
Yeah, almost all of them. So if you need a stool softener, you can use Restorlax. If you need an actual laxative, Senecot, Lactulose, Dulcolax, they're all safe.
2 failed FETs, Euploid. Next FET is next week. Any advice?
Stop and figure out what's wrong before you do your transfer. So 2 euploid embryos should give you an 84% success rate. And we quote this frequently on the show, but the definition of insanity is to do the same thing over and over again and expect a different outcome. So simply following the same protocol and transferring again and again does not result in an improved success rate. It just doesn't make sense. I'm certainly game for doing 2 euploid embryo transfers without doing any investigations, but I wouldn't do a third one until I had some answers. So I would hit the brakes and start looking at testing that will tell you why you failed your first 2. Things we would look at would be the same kinds of things we look at with our either recurrent implantation failure or recurrent pregnancy loss patients. So it's the Fertility infection testing, their immunological panel, thrombophilia screening, sperm DNA fragmentation testing. There's multiple other things. We check your hormones, we look at your thyroid, we look at your vitamin D level, your iron level, make sure your stress levels are low, check your weight, check your diet, make sure you're on the Mediterranean diet. All of these things can be really critical. And then we will frequently incorporate several things to help you, including an immune protocol, heparin. We use aspirin for all of our patients, probably steroids. In one of our previous shows, we determined that one of the immune techniques that works really well is to use sirolimus or tacrolimus. So we've been using that a bit more. We're big fans of intralipids as part of our immune protocols here, so we do that. Subcutaneous IG, or if you have insurance coverage for it and you're in the States, IVIG, all of these can be beneficial in certain circumstances and may help you get a better answer. But would I just jump into another embryo transfer next week? No, I would not. I'd hit the brakes and I'd find out what's wrong, because those embryos are precious and you don't want to keep using them doing the same thing over and over.
Dr. V, what do you recommend for an inositol for someone that has PCOS? What dose do you recommend?
Usually it's like 1,000 to 1,200 for inositol, and it depends if you're using the combination of myo-inositol and D-chiro. So most of the companies that market inositol have the right dosage built into it, but you're aiming for somewhere in that neighborhood, kind of 800 to 1,200 would be a reasonable range. And most of our patients are taking 1,000 or more. So that's what we tend to aim for.
What age is too old for IVF? Embryos were when mom was 38 years old.
That's not a problem. Your age is not relevant. I mean, you got to think more about psychological impact and whether or not it makes sense for the child. But from a medical standpoint, your age is not that important. We can pretty much get almost anybody to respond appropriately. So there are some rare exceptions, but most of the time, even women in their 50s, late 50s can get pregnant with IVF. A 38-year-old embryo source would be entirely reasonable, especially if they were PGTA tested. If not, you just got to understand that your chance of success is lower, but there's still a good chance of success, especially if you have good quality embryos. So there's nothing wrong with trying that.
How does endo lower your chances of getting pregnant? Obstructions, less blood flow to ovaries?
No, not less blood flow to ovaries. So do you want to take this question?
No, this is for you. I appreciate the opportunity though.
So, okay, so you can use or not use, you can look at it from several different perspectives. So there's a direct mechanistic effect because it causes scarring. So if your tubes are damaged or your ovaries are damaged or you have a cyst of endometriosis called an endometrioma, all of those things can contribute to very significant negative outcomes with the ability mechanistically to get a sperm and an egg together and have it land in a nice, happy, healthy environment. Number two is more of a distal effect, which is that the presence of endometriosis overactivates your immune system. And by overactivating the immune system, it has a whole lot of inflammatory cells there ready to attack the endo. Well, unfortunately, those cells can't discriminate between your endo and your embryo. So if they're overactive, they're trying to kill everything in sight. And by virtue of doing that, they frequently will probably attack your embryo as well. In addition to that, there's an overall heightened sense of inflammation, and inflammation and pregnancies don't go together. So those are the ways in which it can impact. There's also a direct physical impact if you're doing an egg retrieval, and this isn't specific to natural conception, but if you're doing an egg retrieval, you will find that sometimes you can't avoid getting around an endometrioma, and you can't puncture them during an egg retrieval because it's a very high risk of infection. So in those cases, we have to avoid the endometriomas, which means sometimes we can't get to all the eggs. If you're just trying it with intercourse and your partner's uncomfortable, obviously sometimes you can't finish ejaculation or complete the sexual act to get to ejaculation because your partner's too uncomfortable. And if it hurts, I mean, obviously it's not going to go very far. So there's a lot of reasons why endo can interfere. The big ones are those immune mediation, inflammatory, and local mechanistic effects.
Can T sperm be tested?
Can what? T? Like the letter T?
T-E-S-E.
Oh, Tessie sperm. Can Tessie sperm be tested? I don't know what you mean. Tested for what? We can't do DNA frag on it. There aren't enough. So we can only look at the quality of what we get. You can look at the quality. You'll know how many are normal and how many are swimming and how fast they're swimming, but you don't get a lot of sperm from a Tessie. So we don't focus on that. We just focus on finding the normal one that's moving, and we use it.
What are potential causes of long follicular phase, 25 to 30 days?
Probably PCOS would be number one. Inadequate stimulation from your brain. So you're either not sending the right signal or you're not sending any signal. Not sending any signal would be people who are too stressed, have an eating disorder, or are exercising too much. And then not sending the right signal would be people with PCOS, or on the flip side, people that are going into menopause.
What helps for RIF with known endo? Is immune protocol worth trying?
Okay, so RIF is recurrent implantation failure. And what's useful for endo? Suppression of the endo would be number one. So 3 months of Lupron and letrozole. And we actually have that in a study we reviewed on the show, where we demonstrated that 3 months of Lupron with letrozole for patients with unexplained implantation failures improve their success rate tremendously. And the authors say that they think it's all because of endo. So that's the number one thing to try. We would also recommend supplements like NAC and coenzyme Q10 and curcumin. All of those can be very helpful as well. In addition to that, surgery, if you can manage to get in for surgery these days, to have laparoscopy to clean the endo, that's also going to be very, very useful. Beyond that, doing an immune protocol, I mean, in my mind, immune protocols probably make sense for patients with endo because we're dealing with an immune-mediated problem to some extent, as I just mentioned a few moments ago. So yeah, I mean, I'm up for that. I think it makes a lot of sense. Would I jump into subcutaneous IG or LIT or something like that? No. But would I try intralipids and some prednisone? Absolutely. I think that's a very reasonable approach to things and can be considered by patients.
What is the process involved in FET? Is there medication? What cycle day does it happen?
Oh boy, that's a big question, right? Yeah. Okay, so you were going to answer that one. So FET is the process of using a frozen embryo to implant in the uterus. So it depends on who you're with in terms of your physician. There's a natural approach, and then there's a modified natural approach, and then there's like a full bore medical approach. So we use the modified approach. But basically the idea, without getting into huge amounts of detail, is to prepare the lining of the uterus, which takes on average about 11 to 14 days. And then further, and that's with estrogen exposure, and then further prepare it by adding in progesterone, whether it's natural or you're artificially adding in progesterone, and then carefully transfer the embryo in. So altogether, kind of like 16, 17, up to maybe, 21, 22 days, 23 days at the far end. All of these are reasonable times within which to do an embryo transfer. The actual preparation mainly involves the thickening of the lining, which is estrogen-based, and then the stabilization of the lining and the luteinization of the lining, which is progesterone-based. What you do in addition to that, for example, with us, use of letrozole, supplements, melatonin, vitamin D, antibiotics, probiotics, that's all center specific, but the gist of it is get some estrogen in there, get some progesterone in there, get the embryo in there. So if you want more details, you need kind of more of a one-on-one because our protocol is pretty sophisticated.
Can you discuss about MC and CAH?
If you're talking about non-classical congenital adrenal hyperplasia, I think you're the same patient that keeps asking every show. So congenital adrenal hyperplasia is a syndrome in which your body cannot properly finish the synthesis of certain steroids and hormones. It's got an enzyme abnormality, usually CYP21, and therefore you can't properly synthesize the mineralocorticoid part of the steroid pathway. Bottom line is you pile up a lot of kind of pre-steroid, which has a very strong androgenic effect, meaning male type steroids. And so what happens is that you get a lot of side effects from it consistent with PCOS. So these would be things like weight gain, acne, oily skin, hair loss from your head, hair growth in all the places you don't want it. And it's all because you're piling up something called 17-hydroxyprogesterone. And because you're accumulating that, it has a strong androgenic impact. And so you end up with these androgenic side effects. What you need to do is take steroids so that that level goes down, and then it corrects the problem.
Is a sonohystogram painful?
Watch our video. So it doesn't need to be painful, although it frequently is if people don't do it right. So the keys to a successful sauna, we've got multiple Instagram posts on this and a whole video. We should be at 35,000 views today, right? Yeah, 35,000 now. So the key is tell the patient everything you're doing. So that's number one. Number two, warm everything you're using, including the fluid. Number three, go extremely, extremely slowly when you're flushing in the fluid. And as long as you do that, and the air as well, it really is very rarely painful. We very rarely have patients complain about the SIS at our office because we go so slowly when we infuse the water that it just doesn't hurt, and we do warm it. If it's cold and you bang it in there, absolutely it's going to hurt like hell, because first and foremost, your tubes will go into spasm and they'll close. And then the doctor's going to think, they're blocked. Let me push more fluid in there. And then that hurts even more because now you're stretching the uterus beyond what it's supposed to be. And that is very, very uncomfortable. So you want a minimal amount of fluid, just enough to see what you need to see, minimal number of air bubbles, you're good to go.
Getting vaccine doses while breastfeeding, safe?
100% safe. Completely, totally, absolutely safe. And as Tarek just told me, our new video on the booster in pregnancy is up as of today. So check out our YouTube channel, hit the subscribe button, and we will happily show you that too.
Hi, Tarek. Hi, Dr. Victory and Tarek. Got ahead of myself. Question. I asked last week in regards to more aggressive steps, injectables after letrozole.
Yeah.
In the event we do not have fertility benefits, can we just choose to use menopause with trigger shots before IUI, in addition to promethium and estrase if needed?
If your diagnosis is anything other than unexplained, yes. If your diagnosis is unexplained, there is good data to demonstrate that the shots alone without the IUI are of no value. And for those of you that are watching the show, on Saturday, I have a presentation on unexplained infertility for the Canadian Fertility Show. So sign up and watch the Canadian Fertility Show. You'll see our presentation there. I have, I think, 35 great slides loaded with frontline, brand new, evidence-based information, including guidelines, recommendations, what works, what doesn't. So check that out for sure.
After 3 failed IUIs, my doctor suggested gone left for the next IUI cycle. Is this right approach? We have been diagnosed with unexplained fertility.
So again, watch this video. So I'll give you a hint on that one. There is a recommendation that you not do the shots if you failed 3 cycles of Clomid and IUI and go straight to IVF. Now, these guidelines don't take people's bank accounts into consideration. They're only looking at the science. So if it's expensive for you, there's no harm in trying the shots and the IUI. But the studies actually show that there is a faster time to pregnancy, a higher chance of having more than one child overall, not at the same time, and that there may even be a cost effectiveness benefit based on the amount of time it takes, how much more you'd have to spend on the drugs, possible failures, and then still needing IVF. So all 3 of those led to a suggestion from ASRM, and I believe CFAS as well, to say that if you've done 3 cycles of oral meds and IUI and you failed, you should basically go straight to IVF. So it's new, but that's exclusively for unexplained infertility, not for everybody else. So in your case, if you've tried 3 times, it might be worth considering IVF. Give us a shout. We'll run over the risks and benefits with you.
What is the reason for no air travel for 3 months after an FET?
A lack of education on the part of the person that told you that. So you can travel after an FET. We don't love it when you do it in the first 6 weeks, just because air pressure changes can probably impact oxygen delivery to the new fetus. And obviously fetuses at that stage are very sensitive, but realistically, there's no reason why you can't try and go ahead and have a flight. But I wouldn't do it in the first 6 weeks. Once the pregnancy is established, you've seen a heartbeat, you're probably safe to go. And we've had bucket loads of patients come see us from overseas where they get an embryo transfer, wait 2 weeks, find out that they're pregnant, and hop on a plane and go to wherever they're going. So that's very common, very frequent.
Does a high 17 OHP results always confirm NCCAH?
Not always, nothing is always, but frequently, yes. Yeah, and it is used to determine if you have non-classical congenital adrenal hyperplasia.
Hi, Dr. V. Third one was pregnant and recently recovered from COVID.
Oh, good.
Is it safe or recommended to get a booster?
If you got COVID recently, you don't really need the booster because it's not going to do anything for you while you currently have antibodies. But your natural immunity will wane over time, somewhere in 3 to 6 months. So at that point, you might want to get another booster. Hopefully by then this stupid thing is over, but who knows? At this rate, it looks like we're all going to be getting boosted every 6 months or so until this dies out completely.
If my OB increases my letrozole dose from 7.5 milligrams to 12.5 milligrams,
Woo!
Then is it a big jump? I made 1 mature and 3 small follicles at 7.5 milligrams last month.
So first of all, taking more letrozole doesn't necessarily mean you'll make more eggs. And I would be wanting to know what the rationale was behind making more eggs. Keep in mind that when you make more eggs, you don't necessarily drastically increase your chances of success. You just drastically increase the chances you're going to get multiples. So taking more is not always the answer if you're trying to get pregnant. If you're aiming for twins, I'd strongly recommend you not. But depending on what your diagnosis is, there are different ways to go about this. So in some cases, you may want to consider doing, for example, Clomid, which typically will make more eggs than letrozole will. In some instances, you may want to add in a little amount of shots because that'll definitely help you make more. But again, you got to do that extremely cautiously because it has been proven to increase complication rates with hyperstimulation syndrome with high order multiples. So it is not something we recommend. You got to be very, very cautious.
Can you explain the difference between the basic and the full microbiome test for fertility?
Yeah.
It's double the price, so I'd love to know the difference. I'm not going to do the immunology one.
So the basic just checks for some bacteria, but not all of them. The full looks for all of the bacteria and viruses and even some of the helpful bacteria. And they also split it into the vaginal and the uterine portion. So it is a little bit more sophisticated. It's more of a headache for me because I got to figure out more things I got to adjust and treat. But I think if you're going to do it, you may as well just do the whole thing. So we recommend to people that they do the advanced one, not the basic.
What do you think is better to take to increase egg quality? CoQ10 or ubiquinol?
Oh, nobody knows for sure whether it's ubiquinone or ubiquinol that's better. So I don't think there's a definite answer on that. I think if you talk to naturopaths, they'll tell you to take the ubiquinol, but some people still think that it's ubiquinone. So we don't know the answer to that for sure. It's the jury's kind of out.
My RE thinks that steroids are not worth the risk of side effects when preparing for an FET after 2 failures. He also doesn't agree with intralipids. Thoughts?
Change REs. So intralipids has pretty good evidence now that it works. So anyone saying they don't agree with it doesn't necessarily know the literature well enough to say that. It's hard to look at the intralipids literature and deny the fact that it has relatively good data to show that it is helpful. Steroids actually does not have great data to show that it's helpful. So I'm willing to, take their opinion on that one. But most of the time it's because it's steroids alone. Steroids in combination with other treatments has been studied far less, but in the few times where it has been studied, there is some evidence that it may be beneficial. With regards to side effects from steroids, I would argue that that's not true. I mean, at the low doses that we're using, if you're using low doses, there are no side effects. So we're using anywhere from 10 to 25 milligrams of prednisone, which is very, very low dose. And intralipids, I mean, we use it all the time, and we've been using it for, 13 years, I think, 12 or 13 years with great results. I mean, it definitely works. There's scientific data that shows that it works. It was just a recent study which showed how it actually impacts endometrial function. So there is no question that intralipids has significant impact. If your RE is saying they don't like it or don't trust it or don't do it, then you probably need to have that discussion with them. And if they're still unwilling to listen, then you go elsewhere. Sorry.
PCOS typically tends to connect it with increased weight gain, but what happens differently in those that aren't overweight with PCOS?
They have less insulin insensitivity, although they still can have some. And they're still irregular. They get all of the other side effects. They just don't get the weight portion. So they can still have the hair loss, the oily skin, the acne, but they don't struggle with their weight. If anything, they tend to typically be on the very thin side. And they don't tend to have as much insulin resistance. So we don't need to use metformin in those patients as often.
Is it true that early cycle FSH levels 10 and below will respond best to letrozole?
So early FSH levels in your cycle being lower mean you'll respond better to everything. It's not just letrozole. If you have a high FSH at the start of your cycle, you're likely not going to respond to meds. So those are cycles where we will frequently cancel. Now, we don't typically check FSH levels at the beginning because if the patient is already in ovarian failure, endlessly waiting for a cycle with a good FSH is hopeless because it's only going to get worse. It doesn't get better. I actually had to let go of a patient years ago because all she wanted to do was monitor her FSH levels to do an IVF cycle when it sort of magically dropped down to normal. And I finally had to say, look, this is not practical. Like, you're not doing the right thing. And she wouldn't listen. I said, look, if you can't trust what I'm saying to you, this relationship isn't really going to work. And I want you to get the care you need and you deserve. And I can't provide that to you because as far as I'm concerned, what you're doing is wrong. And she ate up a lot of time. I mean, literally, I think it was 6 to 8 months when her ovary was already failing. So for those who don't need their FSH level measured because their ovaries are fine, they don't need their FSH measured. So that's not a concern. For those that do, I'm fine with checking it once or twice if they want it. But the reality is time is of the essence and you got to plow ahead or else you're going to lose the opportunity. FSH is not going to go down suddenly. It's always going to continue to get worse.
Hi.
Wow, that took some effort to get that one.
They put hi in a break. I'll give it its due. Hi. Dr. V.
Dr. V. Okay.
See, I'm good at this. I'm in my second round of IVF.
Oh, it was the best.
First round, I did both follicism and menopause.
Follistim.
Yeah, follistim and menopause. But this round, I started with less menopause plus more follistim. And menopause completely removed day 4. Normal?
Tarek's shaking his head no. So like we reviewed in this article, the majority of programs use a combination of FSH and LH. So if you're on just follistim, you're not getting the LH activity. So I would go back to using something with LH, which is menopause, or Luvaris, or one of the urinary derived products, which has contamination with LH in it. But don't do pure Follistim.
What is the difference between an endometrioma and a regular ovarian cyst, and how can you tell on an ultrasound?
That is an excellent question. An endometrioma is a cyst of endometriosis filled with literally menstrual blood. So it's this chocolate brown cyst. When you open it, that all this chocolatey brown fluid pours out, and it's a typically very thick-walled cyst, and they are very stuck to your ovary. I truly love and hate removing them. It's a challenge every time, and you've got to be very good to be able to get them out of the ovary safely without damaging the ovary. So that's what an endometrioma is. There is no such thing as like a garden variety ovarian cyst, because there's like, dozens of different types. There's a follicular cyst, which is just an egg that didn't resolve. There are corpus luteal cysts, which can be normal. There's persistent corpus luteal cysts. There's hemorrhagic cysts. There's multiloculated, unilocular. I mean, I could go on and on. There are solid cysts. There are fluid-filled cysts. There are mixes. So, and then there's, of course, the dreaded dermoid cyst, which has hair and teeth and cartilage and all sorts of crazy stuff in it, oil, lots of hair. So where does this all take us? Well, the short answer with this is that on ultrasound, endometriomas have something called a snowstorm appearance. So let me see if I can find you guys a picture. I don't know if I'll be able to do that while we're chatting here, but endometriomas have a snowstorm picture, and that snowstorm picture is pretty typical on ultrasound. And you can tell it's like a very grainy, kind of gray look to it, and it's filling the entire cyst. So let's see if I can find you an image here. Yeah, that's perfect, actually. Here we go. Okay, I got a screen share to you again, don't I? Whoops, no, that just went to reception. Cancel. Did you get it? Yep, there you go. Okay, so if you guys look at this view right here, which I'm hoping will pop up. Oh, great, it just disappeared. Okay, so let's look at this one. So if I expand this picture for you, does this expand? No, it won't. So if you see that picture up in the upper right of what I'm looking at, you can see kind of a kind of oblong round area, and it's got that very grainy appearance. So it looks like you're driving through a snowstorm. That's basically an endometrioma. Below it, you can see lots of other pictures of the same thing. All of these have this grainy kind of image, and all of these are endometriomas. So that's what an endometrioma looks like on ultrasound. Other cysts don't look like that. Hemorrhagic cysts look very, very close, but they don't have the graininess. It's more of a darker picture than this grainy kind of attribute that endometriomas have.
We are an LGBT couple, and you helped us start our family 9 years ago.
Awesome.
We have 8-year-old twin girls, thanks to your help.
Oh.
We did IVF so I could donate my eggs and help other families. My question is, we have sent in a referral to you and wanted to do an IUI, as IVF was really hard on my body, and I ended up in the hospital with OHSS.
Okay.
This time we want to see if IUI would be an option.
Sure.
I've been told by a few people that IVF lowers your chances of successful pregnancies in the future. Is this true? Would IUI be an option after doing IVF, or are there other factors to this as well? Thank you.
There's absolutely not a shred of truth to that statement. If anything, successful pregnancies following IVF actually increase your chances of success with natural pregnancy or with even IUI. So no, there's no reason why you can't try IUI if you want to try IUI. If you still have embryos, that's certainly something we would consider as well. But yeah, if you guys want to try IUI again, by all means, let me know. And I think I know who you are. So just let me know. By the way, When all of you folks are asking us questions, he's reading them. So I have absolutely no idea who's asking questions. So I think I know who this is, but in any event, yeah, reach out to us and we'll happily help you out with IUI. There's no reason we can't, for sure.
How much NAC to take for egg quality?
1,200.
Nice. Hi, Dr. V. How much selenium should I take as a supplement? I do have hypothyroidism.
400 to 800.
These are the easy ones right now.
Gimmies.
Oh, you're going to like this one.
Okay.
My error results came out. Non-informative. It says that the gene profile doesn't match with the control gene profile in the error predictor. Why does it happen? Is there any specific protocol to do error?
Okay, so most of you who watch know that I'm very anti-ERA. ERA does not work. There are 6 trials, including their own randomized controlled trial, which very clearly demonstrate the ERA test is useless. The only time I use it, and I don't think I've done it for probably 4 years now, 5 years now, is for the patient whose lining simply cannot thicken, no matter what we do. So for those patients, yes, it's worthy of consideration. For everybody else, it's useless. So in your specific case, if you got a reading that they couldn't even get a reading, there's definitely something unusual with your lining. That's something that merits a look. So I'd probably start with multiple ultrasound, saline infusion, sauna, histogram, maybe hysteroscopy with a targeted biopsy. But the ERA test itself is of no value. And even in this, presentation I gave you guys at the start of the show, it says very clearly the vast majority of all these top tier programs are not using the ERA to get their success because the ERA doesn't even make sense. We reviewed a very important study on this show 18 months ago, a year ago, I can't remember right now. But bottom line is it showed that day 5 embryos can be transferred on day 5 or day 6 of progesterone exposure with no difference in outcome. And day 6 embryos should be transferred on day 6 or more because of a reduction in miscarriage rates. I think it's called, is 6 or 7 days of progesterone better? Like progesterone day 6 or day 7, which is better. So that video everybody should watch because it is the death of ERA. Like it proves that day 5 embryos can go in on either day with the same success rate. So the ERA test is useless. Don't bother spending your money on an ERA test unless you have an impossibly thin endometrium and you're not willing to use a surrogate and you want to see if you're receptive. Even then, I'm not using it for the timing. I would ignore the timing. I'm only using it to see if you're even receptive, if the genes are there. There was a study that came out this weekend that I haven't read in full, but where they actually say that they found different markers that are very predictive and even more predictive than the ERA test of the timing of your endometrium, but that it has to be used in relation to a urinary ovulation stick. So it's really hard to understand where they were going with that. But in any event, it's new and it's coming. I haven't read the whole thing yet, but abandon ERA, it's useless. Excuse me.
About to be 44.
Okay.
4 failed IVFs. Retrieved 15 eggs in last cycle, all abnormal.
Oh.
Just recovered from COVID and have no motivation to continue fertility. How many 40+ women give birth at your center?
Well, that's an unfair question because a lot of women over the age of 40 will turn to a donor. So how many over 40 women are successful at our center using their own eggs? About 25%, maybe as high as 30. And I'm including all the over 40s. So there are some that are right at 40 where our success rates are higher. And there are some that are 43, 44 where the success rates are obviously much lower. So in your case, before you start anything, my answer to you would be, no matter where you've gone, 4 cycles of IVF making 15 eggs at a time and not a success is going to need to be thoroughly looked at. I would look at each cycle. I would analyze what they did. I would analyze internally in my own head and say, could I have done better? Could I have tweaked that to get her more euploid embryos? Did they do all the testing that was necessary? Did we fail with euploid embryos? And if we did, why? And then I would tell you if it's even worth trying again, because there is a point at which it's no longer practical to continue doing. That number is actually 6 cycles of IVF. But I mean, that's a lot of money and a lot of emotion and a lot of anxiety and psychological trauma. And, you know, when it doesn't work, it's hard. So I'm not into doing it for people unless I feel that I can do the job to the point where it should be done, and that I'm going to get an answer that's at least reasonable, not by your standards, but actually by my standards. So if I can't fulfill a very high bar for success within my own mind, I'm not inclined to do it. And I'll tell you, you shouldn't. And I do that on a regular basis. I'm very honest with my patients. It's not that I won't do it for them, but I tell them that I don't believe they should do it. So, you know what? I'd love to hear from you. These are the cases I really love working with, because most of the time I actually do find that there's something I can do better, or not necessarily better, but differently enough to get a better outcome. And so reach out. I'll happily chat with you. We can figure out what's going on. Email info@drvictory.com. Ask for a consult. Our consults aren't even expensive. I spend an hour with you, and we'll go over it. And if I think I can help you, I will. And if I think you should stop, I'm going to tell you should stop because it doesn't make sense.
Hi, Doc. VNT.
VNT. Yeah.
Like that. One. Yeah. That's how it's going. One.
Okay.
Do patients not need a rest period for ovaries if they were on the verge of a OHS? 2. More than one IVF is 6 months term. Does it have impact on ovaries and IVF success?
So the short answer is, if you're on the verge of OHSS, your ovaries don't need a break, but it gets really hard to tell which follicles are new and which follicles are leftovers from the last cycle. So I would give you enough time for your ovaries to shrink down just so that we can actually make sense out of your ultrasound. It has nothing to do with your ovaries whatsoever. 2 cycles of IVF in 6 months, even 3 cycles of IVF in 6 months, will have 0 impact on your ovarian reserve.
Hi, Dr. V. If you do 3 months,
Are you seeing this, dude?
I see it.
Okay.
Oh, yeah.
Are there like a million questions?
No. I think we're wrapping it up.
We're wrapping it up. All right. Okay.
Yeah. Yeah.
Do we have a big show? Are there a lot of people watching?
Yeah, it's okay. It's okay. It's for sure not a small show.
Okay. Fantastic.
Normal size show.
Thank you all for watching. Yeah. Okay.
Hey, Dr. V. If you do 3 months Orilissa with letrozole,
Yeah.
and fail FET with a PGT embryo,
Yeah.
do you have to do another 3 months of Orilissa and letrozole before the next FET?
That's a great question. So my answer would be A, no one knows. There's no science on that. But it's probably reasonable to not do it because the suppression should last unless you were on a lot of estrogen for a long time. So if you avoided being on estrogen, you should be okay. And I would just jump into another cycle quickly. If it's going to be a long interval till the next cycle, or you did get very high doses of estrogen, yeah, I'd probably do at least a brief period of suppression again, maybe not 3 months, but a month or 2 with estrogen.
Last one.
Last one.
From Australia.
From Australia.
Yeah, they deserve it.
It's, what time is it? Oh, yeah, it's afternoon in Australia. Okay, fantastic.
Crack of the morning.
Crack of the morning. No, it's actually afternoon. It's
crack of the afternoon.
It's 1 o'clock in the afternoon. 14 hours. It's 1 o'clock in the afternoon.
Brunch.
Fire.
Hi from Australia.
Hi from Australia.
I have PCOS.
Hello, mate.
BMI 24.
Oh, awesome.
Okay.
Yeah.
And just in an IVF cycle.
Okay.
Got 18 eggs.
Amazing. Congratulations.
13 fertilized.
Decent.
All made it to a blast.
Phenomenal.
But only 3 able to be frozen due to fragmentation. Thoughts on this outcome?
Number 1, the lab. Number 2, were your eggs post-mature? Did they wait too long so that they could get more eggs, but then compromise the quality. So your stimulation should have been no more than 11 days, and your maximum follicle size like 21, 22 millimeters. Sperm DNA fragmentation, did they test for that? Do either you or your partner smoke, drink, or use any drugs, including marijuana? That's pretty much it. Those are the major factors that would go into it. So I would look at all of those things. That's a great case to run by me. DM me and we can review it. But my office wants you to go through info@drvictory.com. So email info@drvictory.com, or else you'll all find me being hung. So yeah, don't get me in trouble. Mara will kill me. Okay, so are we done? Pretty much. No, there's a million more questions. Okay, guys. So thank you from Down Under. I love my Down Under patients. You guys are about 10% of our population here. We have a lot of Australian patients. I'm amazed that VRC is so international, but we're thrilled about it. And don't stop watching. Bring your friends. Tell everyone. Make sure you watch the Canadian Fertility Show on Saturday. And check out our presentation on unexplained infertility. There's a lot of great information in there. And I'm not sure if they're going to let me put it up on the YouTube channel, but we'll probably tweak it and add it to our YouTube channel as well. So check out the show. Let us know what you think. And I hope you guys have a great evening. Stay safe and stay off the roads on Wednesday or Thursday because it's going to be hellish around here. Take care, guys.